Let's talk about Tourette syndrome. So this is a disease with a multifactorial cause. There is an association with family history though, and children of people with Tourette syndrome, about 22% of them can have Tourette's. The precise anatomical localization is unknown, although it's thought to have something to do with the cortical connections to the striatum and to the limbic system. Boys are more affected than girls in a ratio of 4 to 1, and it's characterized by motor and phonic tics with onset during childhood, typically between 2 to 15 years. The average age of onset is around age 6. So what are the clinical features? There's normally an urge to perform a tic, which can be alleviated after performing the action, and can also be temporarily suppressed. And this can also be used to differentiate the tic from other similar diseases such as dystonia. There will be waxing and waning severity. I've listed some of the tics here, but this is not an exhaustive list. So motor tics can be simple, such as eye blinking, facial grimace, shoulder shrug, or there can be more complex motor tics, such as body gyrations or dystonic body posturing. There can be phonic tics, such as grunting, barking, throat clearing, sniffing, coprolalia, which means saying obscene words, and echolalia, or repetition of words. The tics generally evolve and change over time, and it can be worsened by stress or emotions. Interestingly, these tics can also persist in sleep, predominantly REM sleep. The neurologic exam and imaging are typically normal. And diagnosis does require 1 year of symptoms or more. So if there is less than 1 year of symptoms, then that's normally called a transient tic disorder, and the prognosis for that is pretty good. It normally spontaneously remits in a few months and does not always require treatment. So the diagnosis also requires motor tics and phonic tics, but they don't have to occur at the same time during the disease. And there's some evolution of the tics in terms of anatomical location, number, frequency, type, and complexity and severity. The onset, depending on which organization's diagnostic criteria you're using, it has to be either before age 18 or before age 21. And it cannot be better explained by other medical conditions such as substance use. So the two most common associations are ADHD, which happens in about 60% of patients, and obsessive compulsive disorder, which happens in about 30% of patients. But otherwise they can have various other comorbidities such as anxiety or mood disorders or learning disability. When do we start treatment? Only when the tics interfere with school or activities of daily living, or if they become uncomfortable or painful. And the mainstay of treatment is habit reversal training with comprehensive behavioral intervention for tics, also called CBIT. But not every hospital will have access to this. So there's also medications. The alpha adrenergics such as clonidine and guanfacine can work. The antipsychotics such as haloperidol, pimozide, and aripiprazole can also be used. Dopamine depletion seems like a good strategy. It gives about the same amount of benefit as the antipsychotics, but it does not have the side effect of tardive dyskinesia. Unfortunately, tetrabenazine is not currently approved by the FDA to be used in Tourette's. If there is a local tic that is especially bothersome, local Botox can also help. So the prognosis is pretty good. The tics generally reduce throughout adolescence and adulthood, and a general rule can be that a third of them resolve, a third of them improve, but in a third of them the tics persist.